Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, and thank you for joining us for a Radiology Vault video. My name is Benjamin Mervak. I'm one of the abdominal imagers at the University of Michigan, and I'll be talking about managing severe contrast reactions in adults today. The goals of this talk are to become familiar with recognizing severe hypersensitivity reactions in adults, how to administer epinephrine without injecting yourself, and how to document what you've done. Immediate drug hypersensitivity reactions are fortunately rare. They occur in about 0.5% of all comers, and even less with gadolinium. But they're potentially fatal, and 2% of reactions are severe. There's an estimated mortality rate of 1 in about 170,000 patients that receive iodinated contrast media. There are some difficulties for radiologists and practices. Namely, there's no standard curriculum to learn how to treat contrast reactions, and so training varies. These are also uncommon events, and so real-world experience varies amongst radiologists. There are some easily recognized signs and symptoms that you can use to diagnose severe hypersensitivity reactions, namely altered heart rate or tachycardia, low blood pressure, hypotension, breath sounds like stridor, or skin changes like flushing and hives. So when a reaction happens, take a deep breath and go see the patient. The first thing you'll do are to obtain some vital signs for the patient. Talk to the patient. Ask yourself, are they conscious? What symptoms are they having? Are they short of breath? Are there any voice changes, or can you hear stridor, because that could indicate laryngeal edema? Check for a patient's pulse, not yours. Is it palpable? If so, the systolic blood pressure is at least 80 to 90 millimeters of mercury. Is the pulse fast or slow? Then ask yourself, what is the severity of this reaction? Is this a mild or moderate reaction? Those would be things like hives, erythema, itching, and no vital sign abnormalities. If mild or moderate, that would be outside of the scope of this Radiology Vault video. However, if the reaction is severe, you should reach for epinephrine because delays are associated with worsened patient outcomes. There are 3 severe reactions for which you should be reaching for epinephrine. The first one is anaphylaxis. Usually this is described as hypotension and tachycardia, although definitions vary. The second severe reaction is laryngeal edema. You should think about laryngeal edema when you hear stridor, which is an abnormality of inspiration, not an abnormality on expiration. You can also think about laryngeal edema if the patient seems to have a muffled voice. Severe refractory bronchospasm is the third reason that you could give epinephrine. This is wheezing that's unresponsive to bronchodilators. So bronchodilators are the first-line treatment for bronchospasm. But if you're giving those and they're not working, then think about giving epinephrine. So what is the definition of anaphylaxis? Well, there's no consensus, although a task force has been convened and is nearing completion on a definition. Most people would agree that anaphylaxis is rapid onset, progressive, has airway or circulatory compromise, and usually has skin or mucosal changes. Another definition is that it's an acute onset illness with respiratory compromise or low blood pressure, and always skin or mucosal involvement. Another definition that is sometimes used is 2 or more of the following: skin or mucosal involvement, respiratory compromise, low blood pressure, and persistent vomiting. This is not just vomiting once or even twice, but recurrent severe vomiting. And as you can see, there are multiple vital sign abnormalities included within these portions of this definition. So for the treatment of any of these severe reactions, it's to give epinephrine. The easiest way to do this is often using an IM autoinjector. This gives a dose of 0.3 milligrams, which is a concentration of 1 milligram in 1 milliliter. You can also give epinephrine IV. although it's a little more complicated. The dose IV is 0.1 milligrams, which is 1 milliliter at a concentration of 1 milligram per 10 milliliters. Meanwhile, you're going to want to lift the legs, give IV fluid like 0.9 normal saline or lactated ringers wide open, unless the patient has severe CHF. You're also going to give oxygen via face mask, 6 to 10 liters per minute, and get help. Call a rapid response or a code at whichever your institution does. And then finally, monitor vital signs during the reaction. So how do we use an IM auto-injector? The first thing to do is to remove the injector device from the plastic case, as you see here. The next thing to do is to remove the blue safety from the non-needle end. After that, you will press the orange needle end into the patient's thigh and listen for a loud click. Know that it's okay to go through clothes or gowns with the epi needle. You should maintain pressure for at least 3 seconds because this ensures administration of the full dose. You can also do a post-injection massage to promote drug uptake into vessels. Also know that you can repeat as needed every 5 to 15 minutes up to a total of 3 doses, although you will need a new auto-injector device for each dose. So here's a little quiz. Which of the following is the correct way to use an epinephrine auto-injector? I'll give a few seconds for you to look at these pictures. A, nothing happens in this scenario. There's no harm, however. The orange tip is the needle end, the business end of the device. Letter B, this is the worst possible scenario. As I said, the orange tip is the needle end, and so by pushing down on the orange end, you've injected your thumb. And now there are 2 patients to take care of. C, this is the best answer. The patient gets the epinephrine, and there's no risk to you because your thumb is not over the end of the device. D is okay but risky. Ideally, you do not put your thumb over either end of the device, just in case you happen to make a mistake. Now, what about IV epinephrine? This is a different formulation, and it's more dilute. It's 1 milligram per 10 milliliters. So to use this, you open the box from the bottom. You can see the arrow here that says press to open. You remove the caps. In this case, this device has yellow caps on it, and you'll twist this glass vial onto the needle very gently. Connect it to the patient's IV line and have IV fluids running or a flush ready to go. You then twist the vial to administer 1 milliliter slowly. Don't push the vial all the way down with your thumb. Just twist it to very slowly administer 1 milliliter. Keep in mind that there are 10 milliliters in this vial, and you're only going to give 1 of them. Do not give the entire thing. Don't push it down because that would be the code dose. So just to reiterate, stop and think. Is the patient coding here? No, they are not. So do not give the full vial of epi. You want to give just 1 milliliter to start. That's 1/10 of the vial. You should be aware of small vials because these are often 10 times stronger. They're intended for intramuscular dosing. So look at the packaging and make sure that it does not say intramuscular or subcutaneous use because that should not be injected IV. And you should know the common concentrations. So intramuscular dosing is 1 milligram in 1 milliliter, and IV dosing is 1 milligram in 10 milliliters. So do not give the IM formulation, IV. When should you call a code? I would say call a code all of the time when you're giving epinephrine. However, you should also call a code if the patient desaturates, if their oxygen level drops below 90%, if they're unchanged after treatment, or if they become unresponsive. And finally, documentation, because if you don't record it, it's like you didn't do it. So what needs to be done? You should document all adverse reactions, whether it's a hypersensitivity reaction or not. Add the allergy in the patient's electronic medical record, and also dictate it in the radiology report. When you have the time, communicate what happened. Tell the patient about their allergy or intolerance, and tell the referring clinician or inpatient provider what happened. So in conclusion, we talked about diagnosing severe allergic-like reactions, how to give epinephrine safely, and what you should do to document reactions. Thank you.